Please welcome to the program now Dr. Barry Lerner. Good morning, Dr. Lerner.
Good morning.
How are you?
Great.
So what do you do now?
I'm a internist at New York University at Bellevue Hospital, and in the rest of my time I do bioethics and history of medicine.
Yeah, so you have a PhD in history as well, right?
I do.
Just one of those annoying overachievers, aren't you?
Career nerd.
No. Well, I don't know about that. And married to a federal judge?
I am.
How's she doing?
She's good. Busy.
I remember when you guys volunteered at the Imus Cattle Ranch for kids with cancer. Your wife was gracious enough to mediate these arguments between me and my wife, which are ongoing. So
she'll have to come down and do it again.
Dr. Lerner's new book, he's written a number of New York Times bestsellers. He writes for the New York Times and other publications. It's entitled The Good Doctor, a fascinating book. It's called The Good Doctor, A Father, a Son, and the Evolution of Medical Ethics. And is this what the book is about? Your dad, a physician, is he still alive?
No, he died about 1.5 years ago.
Oh, God bless him. Your dad, he wanted to kill people and you don't. Was that oversimplification?
It's a little oversimplification. Okay. He certainly thought he knew what was best for patients. Right. He was what we'd call a paternalist and liked to make decisions for all his patients based on his medical knowledge, and including in some cases when he felt that it was time for patients to die, that they were too sick, and that other doctors were prolonging their lives, that he got very aggressive and was asserted that it was time for them to go.
And his motive was what?
His motive was to alleviate pain and suffering.
Right.
I mean, he felt that medicine could do an inordinately amount of good for patients, but at times we use the technologies to prolong people's lives, and they weren't used in a good way. And he was an infectious disease doctor, and he saw this a lot because he kept getting called in to treat infection after infection in patients who had dementia and cancer and from nursing homes who simply were getting worse and worse.
And in a couple instances, when he intervened with patients, your reaction was what?
Well, a couple times I was pretty appalled. The story that starts the book, he actually placed his body on top of a patient who had just died. She did not have a do not resuscitate order, so technically she should have been resuscitated. But he had known her for months and months. She was in agony from pain at all times, and he thought it would have been inhumane to pound on her chest and break her ribs just because the forms hadn't been filled out. And he lay his body on top of her body, prevented the other doctors from resuscitating her, and she died.
Now, I realize that the ethics of this we could discuss forever. But superficially, perhaps, maybe just fundamentally, when you want to prolong someone's life, the decision you make is based on what?
Well, the decision is based, we certainly want to get the input of patients and families and see if they're happy with their quality of life. But I think it's important to realize, again, that the technologies can prolong people for long periods of time when they're not conscious, when they're not going to get better. So we try to weigh the wishes of families and patients, in addition to what we know as doctors, what the best science is.
So is your foremost thought is always what? The patient or the technology?
The patient. I
Right.
think the best doctors can put aside the technology for a minute. They can put aside the results of the blood tests and actually look at the patient, interact with the patient, interact with the family, and try to do what's best.
Now, they talk about a bedside manner with the doctors, and having been to every doctor in New York, I know some of the good ones and some of the not so good ones. Is that something? What happens in medical school? Is that a trait that people either inherently have, or is that something that's taught? Or I mean, like a person's either a prick or they're not. But
no, it's a good question because people in medical schools talk about this all the time. I think there's some people who are particularly gifted who go into medicine at interacting with patients and families, and it just comes naturally to them. But I also think it's good to teach students that, and I think there's a skill set for the ones that need some extra training about ways in which you talk to patients and families, things you should say, things you shouldn't say, and mostly to convey a warmth and interest. I think that's what my dad was particularly good at. People told me that he used to go when he was on rounds for infectious diseases and he would hear a patient in distress elsewhere in the hospital who wasn't even his patient. He would pull his infectious disease fellows off of their rounds, just go into the patient's room and ask what was going on, which I think doctors today rarely do.
We're talking with Dr. Baron Lerner. His book is The Good Doctor, A Father, Son, and the Evolution of Medical Ethics. Well, is the reason they don't do it, is it time?
Time is a huge factor, and I'd be the first to admit that. My dad was lucky. He was a consultant. It was an era when there was more flexibility with payment and billing. So he was actually able, for example, in the afternoons to go round again on his patients. So he would be the first to have said he was lucky to have this amount of time. The challenge for us today when we have to see a patient every 15 minutes is how can we continue to maintain some kind of meaningful relationship with patients? I try at least a couple minutes of every visit to just stop talking about the medicine for a moment and at least ask a couple questions about what's going on in people's lives.
Like, as I told you, I've been to a lot of doctors, as you know, and I asked you if you knew Dr. Ronald McKenzie over at Special Surgery, one of the great physicians who I've ever met, and a person possessed of a unique capability, a marvelous use of the language. Just, we were talking about studying for the ACT and SAT test with my son yesterday and talking about vocabulary and that sort of thing. And then Dr. Lloyd Hoffman, you know him, he used to.
No.
Dr. Aaron Katz.
Yes, I know Dr. Aaron Katz. Yes.
I love Dr. Katz. And Dr. Peekaboo Wu, who is a throat specialist. I mean, these are people at the top of their field and yet have a marvelous rapport with patients. And it's not just me because I see how they are with other people in the waiting room. So that was your dad's strong suit, really? But,
yes.
Okay. And so how did you, in this book, how did you resolve the disparity between your approaches?
Well, I think...
Was it important? Did it get personal? Did it affect your personal? Must have.
Well, we argued about cases. The one I talked about where he lay his body on top of the patient, and I said, you can't take things into your own hands like this these days anymore.
And
he understood that. He understood times were changing, that bioethics was coming in. But it didn't affect
whether you loved each other, did it?
No.
Okay.
We got along very, very well.
Okay.
And indeed, he knew I was writing this book when he was getting sicker, and he knew I was going to tell stories that...
What did he die of?
He died of Parkinson's disease at the end. But he knew I was going to tell stories about some of the things he did that were questionable, and he still encouraged me to do it because he wanted me to be able to write this, and he felt that the stories were instructive to people. I come out somewhere in the middle. I think that we can't go back to the days of paternalism like he emphasized, and we need to talk about informed consent and patients' rights, and patients have the right to do things. But I wanted to try to get doctors to think about how they could reinfuse some of that passion and humanism that he brought to his encounters with patients.
Must have made for a wonderful relationship between you and your dad.
Yeah, it was.
I mean, even though you were arguing about, pretty serious stuff.
Well, the story was he had put me in a white coat when I was 4 years old and brought me to the hospital. So it was pretty clear he wanted me to be a doctor from the get-go. So he was proud of me, and I thought the brand of medicine he practiced was remarkable, but part of me also wanted to challenge that.
Now, I'm sort of disturbed, digressing here, that you put Alan Freed on your musical Mount Rushmore when he didn't have much to do with... I mean, he did coin the term rock and roll. And he did. And he did take a lot of payola. So
he did. No, I know. I felt that if you were talking about Cleveland rock and roll and you didn't mention him, it would be an omission.
Well, you're right about that.
Yes.
So, and the great Joe Walsh. And were you a fan of the James Gang and all those?
Yes, of course. Right. Growing up there, we all knew those guys, right?
Where did you live in Cleveland?
University Heights, so in the eastern suburbs.
Yeah.
So.
Well, nice to see you again. Say hello to the judge, your wife.
I will do that.
And this is a wonderful book, and I hope it's a huge success for you.
Thank you so much.
The Good Doctor, something everybody should read because everybody goes to the doctor. So, The Good Doctor, A Father, a Son, and the Evolution of Medical Ethics. It's available obviously everywhere, mostly Amazon's what you should do, and you just go to Amazon, and it's not very difficult for you. You just type in The Good Doctor, and it'll pop up, and you click on it. Anyway, thanks, Doc.
Thank you.